This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now. I'll be strong. I'll play my fight song. And I don't really care.
Hello everybody, welcome. So what we decided to do was something a little different, based basically on what people had asked us, and it was all very good to roll out the guidelines, but they wanted something to where they could see why those guidelines were changed and see some of the subject matter experts actually explain why that happened. So we decided to try something a little newer this year, and if this works out, we'll do it again in the future. A couple of people we'd like to thank. Life Care Medical Transports have very generously sponsored us financially so as we could put this on. And as I say, there'll be 3 or 4 of these based on the major changes. We certainly can't do them all, but we'll try to highlight the things that have changed and the changes that have gone on since 3 years ago when we last did the guideline changes and rollouts. So with us this morning we have Dr. David Burt. And Dr. Burt is an Associate Professor of Emergency Medicine at the University of Virginia. He's Director of their Chest Pain Center, and he's a founding member of the Virginia Heart Attack Coalition.
Morning, Tom.
Morning, how are you?
Not bad. I worked all night, but I'm functioning reasonably well.
So what we're trying to do here, if we can, is obviously we can't go through the whole thing. We're trying to make these fairly short vignettes and easy for people to watch. We want to go over the things that have changed in the last 3 years since the last official rollout of the guidelines. Some of the things that you've seen in practice that you think are challenges for us, things that are going particularly well and we really need to keep going. And basically take about 10 minutes or so to go through them. So one of the big things that people talk about, and we've tried to do here in the council, is address who should be doing 12 leads, when they should be done, and really establish that it's not just a procedure, there's some real value, you know, to the patient in the actual outcome and how well that patient does and how well their life does going forward. So it has been for many, many years probably considered, maybe incorrectly, but the acquisition of 12 leads was something that was a medic type thing. And we know now from all the research that the more 12 leads you get, the better off it is, and that just doesn't jive with a very small group of people doing. So what do you recommend as regards who should be acquiring 12 leads in the field?
Well, Tom, that's a great first question. I think that over the past number of years, we've seen a big change, as you mentioned, from this idea that a 12 lead is something that you do occasionally to really right now the ECG is a vital sign, which means if you've got anything going on between your nose and your navel, basically, we need that provider, whoever that is, to be able to put the leads on the patient, get a reasonable 12 lead, because, for example, if they have a heart attack and it shows up on that, that's the greatest potential time to make a big jump in outcomes. So 12 leads for everybody, all providers doing 12 leads. I think the jury's out that that's where the nation is, and if we're not there yet everywhere, I think we soon will be, 12 leads for everybody.
So from that you're saying that the old sort of way of looking at it, that it's a medic-only skill. This is a skill that should be performed by the BLS providers also.
Absolutely, yes. And either that's officially mandated or I think the practice is more and more every year. Everyone on the rig should be doing one.
And you're going to find in the guidelines that from a very small selected group of patients that would normally get 12 leads, just like you said, from your nose to your navel, there's a huge list now. And I would think, would it be fair to say, rather than worrying about that list, take the mindset that most people should get a 12 lead.
Yeah, if you've got someone over 30 and they've got heartburn, indigestion, tachycardia, palpitations, chest pain, chest pressure, they're throwing up. We've all seen, you know, time and time again where a 12 lead on those patients, most of the time is not their heart, but when it is, it's a game changer, and you can't get that diagnosis unless you do the 12 lead.
Right, so one of the big things that people, we have in the guidelines is people with nausea. And people would say to me, look, Tom, if you do a 12 lead on every guy who has a little nausea and vomiting, you're going to kill 10,000 trees just printing off all those things. But in the reality, a lot of those patients get missed because their complaint is nothing that's your typical acute coronary syndrome. So can you give me an idea of really, it's easy to say that, but is that really true? Do we miss people?
Well, we do, and I always look at it this way. The same nerve that goes to your stomach, it goes right to your heart. So when either one of those acts up, nausea may be what you have. And so I QI every STEMI that comes through UVA, for example. And one of our recent near misses was somebody with nausea, picked up at a skilled care facility, didn't get a 12 lead from EMS. Our first provider didn't get a 12 lead, and then our tech said, hey, nausea needs a 12 lead, and that was a massive anterior infarct. We almost missed that.
And the end result of that, it was missed, from what you're saying, in 2 out of the 3 events. If that had been missed the 3rd time, just in simple language, the end result for that patient could well have been.
Yeah, they would have perhaps sat in their hallway, gotten some fluids, and then at some point we would have figured out it wasn't their stomach, it was their left ventricle that wasn't feeling well.
So this fellow sits there, and this is the point we're trying to get across, is that yes, it is a greater workload to do these, and they're not without time commitments to do them, but it's a greater workload. But the difference between this guy, and I know you and I have done a video on this with the STEMI Roadshow before, and there was an analogy given then of a guy who has chest pain at one of his grandchildren's sporting events. And we were trying to show the difference between the patient survives, but it's done very efficiently versus it's done in a very slow, long way. And the analogy we gave them was the next time he goes to the sporting event with his grandkids, he's not going to throw a ball around them, he's going to sit in a chair and watch them. And so these delays, it's not a question of survival, it's function. Is that fair or reasonable thing to say?
It is. You know, one of the things about statistics is they don't tell you everything. So say you have a guy or a lady with a big infarct, and over 5, 10, 15, 20, or 80 or 90 minutes, every minute there's some myocardium dying. And if the pre-hospital provider does the 12 lead at 10 minutes, and we have a diagnosis, boom, that patient's going to get reperfused quickly. If you wait another 40 minutes, they're still going to get reperfused, but they're going to have a larger percent of their heart gone. And so they may not die, but in 5 years, they're going to be a cardiac cripple. If we would have got to them in 10 minutes, they're playing basketball with their kids. If we get them in an hour, they might be alive, but they're crippled. And if we never get to them, they're going to die, because the 30-day mortality of a missed LAD infarct is 50%.
So I mean, it's very obvious that not alone do you need to get to them for survival, but if you don't get to them in a timely manner, their life is badly altered where it wasn't necessary that would necessarily be. And so that's a reasonable segue into one of the things that we wanted to mention was Dr. Burt and I have talked about this 10-10-10 concept, and what we're talking about time and the impact that has on patients' lives afterwards, both saving their lives and the quality of their life later on. Tell me something about this 10-10-10.
Great point, Tom. So the 10-10-10 idea is saying in today's heart attack care environment, what really matters. You know, door to balloon, that's STEMI 2010, but STEMI 2018 means 3 things. If I'm an EMS provider and the patient has symptoms, how quickly do I get the 12 lead? 10 minutes. If that 12 lead has definite STEMI findings or I'm suspicious, I should be contacting the likely facility in 10 more minutes, 10 and 10. And finally, if I talk to the physician at that facility and she and I together think it's a STEMI, they should be activating that internal cath lab within 10 minutes. And that means 10 minutes to do the 12 lead, 10 minutes to contact the facility, and 10 minutes for that facility to make a decision, so that if I show up, the cath lab is ready to go. We're not trying to get to the ER this year. That was 10 years ago. We're trying to get to the cath lab, and that can't really happen unless you do the 12 lead and you call the facility, and then the facility opens the doors for you. So 10-10-10.
So in practical terms, for us that are EMS providers, you're talking about 10, 10, 10, and that first 10 minutes particularly, that's 10 minutes from when you show up, you should have got that 12 lead. So that should be done in the house or wherever it is you meet the patient, correct? Not waiting to get in the truck, knowing that we can't judge every call being the same, but ideally we'll give the scenario of going to a house to see somebody. That should be done in the house, right?
In most cases, I would say, yeah. If you're going to grandma's house, and I always talk about our patients as grandma, she's someone's grandma. If she's got symptoms of a potential heart attack, then the 12 lead immediately becomes the vital sign of most interest, provided she's not, profoundly unstable.
Right.
So we need to get that in the house, because if we don't get it right away, upon eyeball time, face to face, then we're losing that time to make that decision phone call if she is that one STEMI of the month or the week or the year. So that critical diagnostic 12 lead should be done at the scene when all possible, yeah.
So again, trying to apply this to practical terms to the folks who are actually doing this in the field, that probably would be a situation, if we could suggest, where you're going to have at least two people. Somebody is doing some initial set of vital signs or history taking or whatever, but simultaneously the 12 lead is being done. And I think sometimes we tend to look at things as individual events, and we certainly do a lot of very good things, but the value we get is when you do a lot of value-oriented things that pay off, but you do them all together. So you're using that one time frame to meet multiple benchmarks. So I think to do certainly your evaluation and your exam and your history taking, and that other person getting that 12 lead. So there's no time lag to wait to get it. Then the other question I would have is, so now you have this 12 lead. And most places nowadays have the ability to transmit it, but some don't. What good is that 12 lead to me now? How am I going to change that 12 lead into something that's actionable on the other end, and the other end being whoever is getting the patient, the receiving facility? How do you suggest that order should go once the machine spits out that 12 lead for you?
Well, I guess that gets down to STEMI philosophy, right? If you do a 12 lead and no one hears about it, you haven't done a thing to help the patient. So you got to call the facility. Now, this is really critical, and I think this is where we're going to focus the next year or two, is that without that phone call to notify the facility, giving them the chance to pre-activate their cath lab, there's nothing being done at that facility to make reperfusion happen any more quickly. So if you get a 12 lead and you call me in the ED and I talk with you, even if you can't transmit that image, at least 40% of the time, and this is what we see at UVA, is we'll activate that cath lab anyways, just based on the phone call. Now, we'll never activate it on just the image. An image pops up on the screen with no phone call. But if you can't transmit because of topography, and 50% of the time in our area you cannot, give us a call. Establish that contact. If you're way out there and you're calling for air EMS intercept, call us as well. Don't just call them, but call us, because we're the place that makes the difference. And in order to open the cath lab, we've got to have a voice-to-voice powwow.
So that brings up probably three questions out of the thing that as an EMS provider, I think it's fair to ask Dr. Burt, because it's certainly been asked of me several times. We have this 12 lead, and at one point a lot of places said they really wanted the 12 lead or they were not activating any cath labs. From what you're saying, having that telephone call is more important than actually having the piece of paper to see. So would that be correct?
Well, if you just send me the 12 lead, we call that a phantom. We don't do anything with that. If you call me, we'll do something with that. And then if you can call me and send the image, it just makes it a little bit easier. But a lot of these STEMIs out there are pretty obvious. And you pick up, look at it, and grandma's got elevation in 2, 3 AVL with reciprocals and her anterior leads, and so forth and so on, describing that over the radio or over the phone, and it comes ... acute MI across the top, and grandma's having symptoms, that's pretty easy decision making, but it only happens if we have a phone call.
So the other thing is, if we could pose the scenario, is I'm a BLS provider, and I have hopefully looked at the criteria, and I've done a 12 lead maybe on somebody who we always would have, or maybe I've decided that I'm going to do one and that wouldn't normally have been done. And this machine spits out, now it doesn't really make a lot of difference, I think, which product you're using for your cardiac monitors. The algorithm in there is nowadays sufficiently good to make decisions based on it. So I'm a BLS provider, and I'm told and encouraged, and it's not within my scope of practice to interpret, certainly to require, but not to interpret. I should feel equally confident of calling you and, if possible, sending that 12 lead. Because the third and final part of that question is, one of the great things I hear is, what happens if I get it wrong? And I set off a whole chain of events. People get called in, it's 4 o'clock on a Sunday morning. I'm going to catch holy hell for that. What do we do to reassure those people, no, you've done exactly the right thing?
Great question. Well, one, if you call in and talk to the physician, he or she can sometimes act as a filter. For example, if someone's 28 years old and they have pleuritic chest pain and their ECG says acute MI, they could be benign early repole or pericarditis, but they certainly don't clinically sound like a STEMI. So that might be someone I'll say, thanks for calling. We'll see you right away when you get here. I'm not going to activate the cath lab yet, but we're on notice. Secondly, if you do all the right things and the patient doesn't have a STEMI, great, celebrate that with them. It doesn't mean that the system didn't do exactly the right thing. So if you do the 12 lead and it's a reasonable call and you call us and they don't have a lesion, no big deal. Thirdly, if someone grouses at you about that, that's their problem, not yours. We all need to grow up. And last but not least is that you can't be 100% right all the time, because if we are, that means we're probably leaving a few STEMIs out there. And some of them are hard to pick up. Even cardiologists can't always agree. What we're looking for are the easy ones, and this is all to make the easy ones a little easier.
So I think for you and I as EMS providers, the take home from that is, regardless of who you are and what your thought process is, if it's reasonable to think from the history and the physical exam that this is some form of an acute coronary syndrome and or STEMI, set the wheels in motion to deal with it. If you're a BLS provider, do the right thing. Get the 12 lead, send the 12 lead, and please call. And what happens downstream, if ultimately the few patients that will be activated for the cath lab in a STEMI alert, if they don't turn out to actually have the occlusion we thought they had, that's fine. It's far better, certainly for me, my advancing age, not to be missed. I would far rather that somebody didn't write me off and I have a big STEMI, I have damage, and it limits my life forever. So the take home from that, as I say, is we're encouraging you to do it and we'll support you to do it. So please go ahead and do that. So another question I would have for you is Project Lifeline and the AHA, they have now come out with some metrics to where they will be looking at EMS performance, not necessarily, a lot of times the performance metrics were how did the ER take care of it, how quick to the cath lab, how quick did the cath lab behave when they got it. But now be looking at how the care happened pre-hospital. Can you give us a little explanation about what that is?
Well, Tom, last night at work I actually went to the American Heart Association's Mission Lifeline STEMI Initiative website. And yeah, they're looking at pre-hospital performance, trying to understand what really makes a difference. And so they have 6 metrics. And each individual EMS agency can submit your performance on these to get Mission Lifeline recognition for your agency, independent of what happens at the hospital. And it's interesting, but 3 of those metrics, number 1 is if your patient has chest pain or symptoms over age 35, did you get a 12 lead or not? Yes or no? 2, if you got a 12 lead on that person, did they get it within 10 minutes of eyeball contact? And 3, if you thought it was a STEMI, did you make first contact to a facility in, you got it, 10 minutes or less? So that 10-10-10 initiative that the council has been promoting is directly in line with now what AHA is saying is optimal STEMI care for pre-hospital providers. Do the 12 lead. If it's a STEMI, call us. That's it.
So when you do the 10-10-10, you end up with sort of, it's presuming that you ultimately have 30 minutes just by adding them up. But several of our agencies are in this small catchment area within the whole call is less than 10 minutes. So getting a 12 lead, calling somebody, hopefully sending it, if you add up that time, as it's represented in a percentage of the care time, the transport and everything, they don't have an awful lot of time. So given that you might not be able to do all those things, and I think we agree the goal is whatever you do not to slow the patient potentially getting to the cath lab, having his vessel opened and be reperfused. If you had your wish list, say I'm here or maybe in the city of Charlottesville where I might be 8 minutes total contact before I see him and then he sees you, what of those things would you rather I did most?
It's simple. Call us. I'll tell you why. If you're 8 minutes out and it's during the day and the cath team's getting ready to slide somebody else on the table and they get a heads up, STEMI en route, they freeze the table and they get ready. It's worth slowing down to make the phone call because that lets us start the cath lab process more quickly. And if you went to the cath lab director and they said, what's the optimal heads up time? They would say 30 minutes minimum, 45 minutes is great, 1 hour is perfect. Meaning anything within 1 hour of us, the quicker we get a phone call, the better for the patient, even if you show up in the ER a couple minutes later because you stopped to make a phone call. If you wait long enough, you'll just slide right through the ER and go to the cath lab.
And that'll work for probably about 70% of the agencies in our region. But the 2 agencies that are around here, you're never going to make that. They're going to be very, very quick. They're going to be there quicker. So we've talked a little bit about the process and how most expeditiously you can get these patients to the cath lab and hopefully get their vessel opened and end up with a good result for them. Obviously there's more than that to it. These patients have to be taken care of. They require their meds, they have other things that they have to be done. There are some important changes that we made. Again, we can't, because we're doing this in short vignettes, we can't go through them all. But there are a couple of things worth noting that you will see that have changed when you look at the guidelines. We have changed some of the nomenclature. A lot of it was written quite a long time ago, and IV access or vascular access was IV. So the nomenclature has been changed there, and we're putting vascular access procedure, a vascular access procedure, because of course there are now in use lots of, whether it be interosseous or whatever. So that's how we've changed the nomenclature to give you that option to obtain your vascular access, however is most appropriate and available to you at the time. CPR in the resuscitation of patients. While the guidelines, we do obviously recognize the AHA guidelines of 30 to 2 and what have you, but we have written into the new guidelines, where possible, continuous good CPR. So if you're not doing something that is vital, and there aren't very many things that there would be in the resuscitation phase in the arrested patient, continuous good compressions is what we're looking for. Obviously, you're not going to continue doing them if you're going to defibrillate somebody, but I can't imagine any other times to where you should not be performing CPR when it's needed. Is that reasonable?
Yeah, totally, unless the patient wakes up and says, don't do that.
Well, that's probably a hint.
Yeah,
That's
and
what they
then
call a
it's a
clue.
big success. But yeah, what we understand is that continuous CPR is the most important thing. Like you said, unless you have an absolutely great reason, which would be defibrillation and not much else.
Also, in some of the medication changes, adenosine for SVT. And a lot of people since the last guidelines changed 3 years ago, people have sort of flip-flopped back and forward. Should you give an initial dose of 6 milligrams and follow that up by 12? And we have, in this latest rollout, we have eliminated the 6 for the initial dose, and we've gone with 12. So that's what you're going to be doing for right off the bat. It'll be 12 milligrams. So hopefully that's made some sense to you. Obviously, we couldn't go over all the guidelines, and certainly I encourage you to read them all. Just remember as well that they're not just a document sitting in a book somewhere. We provide them to where nowadays all you have to do is have your phone. And if you go to our website, tjems.org, you'll see the instructions. You can get it for Android, you can get it from Apple. And I would say, I know in my case, that it's very hard to memorize all these things. And there is nothing at all wrong, and I'd suggest it's good practice, that especially when you went up against something that you haven't seen in a while, there's nothing wrong with pulling your phone out and double checking. Double checking is a great way of preventing mistakes. And it's not a sign of any lesser ability on anybody's part. I know personally, when it comes to doing drug calculations, yeah, I may know how to do them, but I check them on the phone. I use the calculator, and I think that's good practice. It's not at all something that implies some sort of lesser form of practice. So we've gone through that. We're going to go through another series with trauma, stroke, and medical. We hope you've enjoyed it. We hope that it's something that's useful to you. It's something that people have said they maybe would like. A couple of people we have to mention again that we would never have been able to do this with, thanks to Hoopla Media, who are actually producing this for us, and again to Lifecare Medical Transports, who financially support us in these videos and without whom we couldn't do them. So we'll see you again next time with the next of the guideline updates. Thanks.